Hey guys, welcome to our new video in the endocrinology series on USMLE with Warren. So, in this video, we'll discuss about the adrenal glands, which are also called as the suprarenal glands. So, adrenal glands, we have known and studied about these glands in our medical school already, and we just need to understand how it regulates our body metabolism and how it regulates electrolyte balance in our body in order to solve questions on USMLE. So before diving into the video, I would like to request all of you to subscribe and keep supporting. So this lecture series is provided free and is open access on this open access platform like YouTube. If you find it useful and wish to support its continued development, you can contribute voluntarily. You can pay me with the link that is on the screen and also pinned in the description. You can pay with any of these payment methods at this Razor Pay link. Any contributions will help enrich and better the quality of our lecture series and educational content. So in this video, we'll study the adrenal glands, which control the stress response, blood pressure, electrolyte balance, metabolism, and some sex steroid production. So for exams, this topic is high yield because many diseases look similar, but they differ by simple clues like blood pressure, electrolytes like potassium and cortisol levels. If you understand the pathways and regulation, you can solve questions logically rather than just memorizing all those hormone lists. If you understand the logic of the pathway and how the regulation happens at the gland level and at the cellular level, you can solve any questions very easily. So, each adrenal gland has two parts. The cortex makes sex steroids or the steroid hormones, and the medulla makes catecholamines. The cortex makes steroid hormones and the medulla makes catecholamines. The cortex is controlled mainly by the ACTH and the renin-angiotensin-aldosterone system, while the medulla is controlled by the sympathetic nervous system. A simple rule is equals cortex uh, regulates steroids, whereas medulla releases and regulates catecholamines. The adrenal glands sit on the top of the kidneys, so they're called as suprarenal glands. They are retroperitoneal and are highly vascular. The right adrenal lies near the inferior vena cava, and the left adrenal gland lies near the aorta and the left kidney. Because they are so much vascular, because they are highly vascular, adrenal tumors can cause strong systemic effects. Now let's try to differentiate the embryology of the adrenal cortex and medulla. The cortex comes from the mesoderm and the medulla comes from the neural crest cells. That neural crest origin explains why medullary tumors behave like neuroendocrine tumors and why the medulla functions like like a modified sympathetic ganglion. So there are two parts, adrenal cortex and adrenal medulla. The cortex is derived from the mesoderm, whereas the medulla is derived from the neural crest cells. Neural crest behaves like sympathetic nervous tissue. So these medullary tumors behave like neuroendocrine tumors, and the medulla functions like a modified sympathetic ganglion in that case. So, pheochromocytoma is an example of such a neuroendocrine tumor. From outside to inside, the zones are zona glomerulosa, zona fasciculata, zona reticularis. They make aldosterone, cortisol, and androgens respectively. The glomerulosa makes aldosterone, whereas the fasciculata makes cortisol and the reticularis makes androgens. GFR in the order. Glomerulosa secretes mineralocorticoids, fasciculata secretes glucocorticoids, reticularis secretes sex steroids. So we can memorize it as GFR. from outside to inside. Glomerulosa, fasciculata, reticularis, the three zones of the adrenal cortex, and they are involved with salt, sugar, and sex. So, aldosterone by G, cortisol by F, and androgens by R. All adrenal steroids start from cholesterol and are synthesized in the mitochondria and smooth endoplasmic reticulum. This means enzyme defects at any step will predictably change hormone levels. So each steroid made in the adrenal cortex starts from cholesterol. It is synthesized inside mitochondria and the smooth endoplasmic reticulum. It uses specific enzymes at each step. So if there is no cholesterol, there is no cortisol, there is no aldosterone, there is no androgen production also. So whenever we need to identify which enzyme block is present in a case, we have to look at the hormone levels because enzyme defects at any step will predictably change hormone levels uniquely. So the first step and the rate limiting step is cholesterol to pregenolone by desmolase in the mitochondria. This step is stimulated by ACTH. So ACTH broadly increases steroid production. The first step and the rate limiting step in the synthesis of any of these GFR, glomerulosa fasciculata reticularis hormones, the first step and the rate limiting step includes conversion of cholesterol to pregenolone, uh, which is enhanced by an enzyme called desmolase in the mitochondria. This desmolase is also called as cholesterol side chain cleavage enzyme. This desmolase is present in the mitochondria, and this step of conversion of cholesterol to pregenolone is stimulated by ACTH. ACTH increases all steroid hormones by increasing this cholesterol to pregenolone step. So when ACTH acts at the level of the mitochondria, the activity of desmolase enzyme is enhanced. So as a result of that, more cholesterol is converted into pregenolone, and more pregenolone leads to more steroid hormones. From pregenolone, the pathways diverge. Aldosterone is mainly from zona glomerulosa, cortisol is mainly from fasciculata, and androgens from the reticularis. Each zone has different enzymes, which explains different diseases. ACTH mainly regulates cortisol and androgens and overall steroid hormone synthesis. Aldosterone is controlled mainly by the renin-angiotensin-aldosterone system and potassium levels in our body, not ACTH. RAAS and potassium levels control the aldosterone synthesis in our body, but it's not the uh, ACTH that controls. So ACTH regulates cortisol, androgens, and the overall steroid synthesis, whereas RAS plays main role in the regulation of aldosterone levels, the hormone from the zona glomerulosa. This is mainly regulated by RAS and potassium levels via angiotensin 2. So when blood pressure or sodium is low in our body, the kidney releases renin, leading to synthesis of angiotensin 2, which stimulates aldosterone release. And this aldosterone release increases sodium and water reabsorption and increases potassium and hydrogen excretion. So aldosterone raises blood pressure levels because it increases sodium and water reabsorption. It leads to increase in the blood pressure. It lowers potassium and hydrogen levels, causing metabolic alkalosis. Because it increases hydrogen excretion from the body, it leads to metabolic alkalosis. And this hormone also leads to vasoconstriction. Now let's study about cortisol, which is often called as the stress hormone. Cortisol is made in the zona fasciculata and is essential for stress response. It affects metabolism, blood pressure, and the immune system. So, cortisol helps the body to survive stress by mobilizing energy. So, it is called as the stress hormone. Now, coming to the metabolic effects of cortisol, cortisol increases gluconeogenesis, protein breakdown, and lipolysis. And by doing all these three things, it raises the blood glucose levels. Chronically, high cortisol causes diabetes, muscle wasting, and thin skin. Thin skin. Cortisol is a catabolic hormone. This cortisol is a catabolic hormone. So now coming to the immune and inflammatory effects. Cortisol suppresses immunity and inflammation by reducing cytokines and stabilizing lysosomes. That's the reason why steroids are used as anti-inflammatory drugs. They decrease inflammation and decrease cytokine production, and they stabilize the lysosomal membranes. So they produce an anti-inflammatory effect. So these steroids are also called as anti-inflammatory drugs. But uh, high cortisol or steroids is a risk factor for increased infection because they're anti-inflammatory, they reduce inflammation, they increase the infection risk. Now, coming to the cardiovascular and permissive effects, cortisol increases vascular responsiveness to catecholamines and helps maintain blood pressure. So, what does this cortisol do? It increases the vascular response at the level of the alpha 1 receptors to catecholamines and helps maintain the blood pressure. It enhances the uh, effectivity of catecholamines at the alpha 1 receptors and helps maintain the blood pressure. Without cortisol, patients can go into shock. So this is called as a permissive effect. Cortisol has permissive effect on catecholamines. So cortisol has a permissive effect on catecholamines. So we have already studied in our medical school that there are different enzyme effects like permissive effect, potentiating effect, synergistic effect, additive effect, antagonistic effect. So permissive effect is one of those categories of effects at the enzymes. So what does this cortisol do? It enhances the responsiveness to catecholamines at the level of the vessels and increases and enhances the response of catecholamines. So it helps maintain blood pressure. So without cortisol, what happens is the blood pressure drops and shock can occur. Let's study about regulation of cortisol secretion. The hypothalamo-pituitary axis controls the cortisol. CRH from the hypothalamus, ACTH from the pituitary, and cortisol from the adrenal. All these regulates the cortisol secretion. Cortisol gives negative feedback to both CRH and ACTH at the level of hypothalamus and pituitary. Both these levels, there is a negative feedback acting. So let's study about the Cushing syndrome. Cushing syndrome means excess cortisol from any cause. The most common cause overall is exogenous steroids. Exogenous steroid, either by an injection or uh, what do you say? Exogenous intake or exogenous usage of steroids is the most common cause of Cushing syndrome. Cushing syndrome specifically means pituitary ACTH secreting adenoma. So Cushing syndrome is specifically a ACTH secreting pituitary adenoma. Ectopic ACTH production occurs in case of small cell lung cancer, and adrenal tumors produce cortisol. So Cushing syndrome is high cortisol from any cause. So Cushing disease is high cortisol from pituitary ACTH. So Cushing syndrome and Cushing disease. So both these conditions are different. Cushing syndrome means excess cortisol from any cause, syndrome, any cause, whereas Cushing's disease is mainly due to pituitary ACTH secreting pituitary adenoma, ACTH secreting pituitary adenoma. So that's the disease is mainly related to pituitary adenoma with excess of ACTH. The clinical features of Cushing syndrome, the classic features includes moon face, buffalo hump, central obesity, thin skin, purple striae, eye bruising, proximal muscle weakness, hypertension, and diabetes. So whenever you see a question mentioning fat redistribution with muscle wasting as a key pattern, and the question also mentions skin changes, we need to first think about Cushing's syndrome, a fat redistribution along with muscle wasting. So the features includes central obesity, buffalo hump, thin skin and bruising, purple striae, proximal muscle weakness, hypertension, diabetes, moon phase. So all these are clinical classic features of Cushing syndrome. Personality changes are a possibility. Hyperglycemia because of elevated cortisol levels, CNS irritability, moon phase, susceptibility to infection because it has an anti-inflammatory effect, sodium and fluid retention, elevated blood pressure. Males may show features of gynecomastia, thin extremities, fat deposits on the back, buffalo hump, GI distress, increased acid production, amenorrhea and hirsutism in females, thin skin, purple striae, bruises and petechiae, and osteoporosis. So these are some features of Cushing syndrome. Now coming to the screening tests for Cushing syndrome, the common screening tests includes we screen with low dose dexamethasone suppression test, 24-hour urinary free cortisol testing, and late night salivary cortisol. In Cushing syndrome, cortisol does not suppress. In Cushing syndrome, cortisol is not suppressed. So normally cortisol should be suppressed by dexamethasone, whereas in a patient with Cushing syndrome, this cortisol is not suppressed. The first step is we have to screen for hypercortisolism. The first step in uh, a patient who presents with features of Cushing syndrome, when we try to screen them or when we try to diagnose them, the first step we have to do is we have to screen for hypercortisolism doing these three common screening tests: low dose dexamethasone suppression test, 24-hour urinary free cortisol, and late night salivary cortisol testing. So now let's try to differentiate and understand between ACTH dependent and ACTH independent Cushing syndrome. After confirming high cortisol, we need to check ACTH levels. If there are high ACTH, it means ACTH dependent causes like pituitary or ectopic ACTH, whether in the case of pituitary adenoma because of excess production of ACTH or because of ectopic ACTH production from uh, paraneoplastic syndromes of cancers like small cell lung cancer. And low ACTH means adrenal tumors or exogenous steroids. So ACTH level tells you where the problem is. So after confirming high cortisol, we need to check ACTH. So check ACTH as ACTH dependent, Cushing's disease, pituitary, ectopic ACTH, small cell lung cancer, low ACTH, ACTH independent, adrenal tumors and exogenous steroids. Now let's try to understand about the high-dose dexamethasone test. With high-dose dexamethasone, pituitary Cushing disease shows partial suppression, but ectopic ACTH and adrenal tumors do not suppress. Pituitary Cushing disease shows partial suppression with dexamethasone, but ectopic ACTH and adrenal tumors do not show any kind of suppression even with dexamethasone. So whenever there's suppression of cortisol levels with high dose of dexamethasone, we need to think about a pituitary source of ACTH. When we try to understand about adrenal insufficiency, we need to know that adrenal insufficiency means inadequate cortisol, sometimes with aldosterone deficiency. It can be primary, secondary, or tertiary. Always ask whether the problem is in the adrenal gland or upstream of the adrenal gland. So, primary, there is a problem in the adrenal gland itself. So, the example is Addison's disease. The secondary type of adrenal insufficiency includes if there is a problem in the pituitary and the main cause is low ACTH production. Whereas tertiary type of adrenal insufficiency includes there is a problem in the hypothalamus or there is chronic steroid suppression. So primary at the level of adrenal gland, secondary and tertiary at the level of the hypothalamo-pituitary axis. So We have already studied in this that the primary cause, the example is Addison's disease. So now let's try to understand about this Addison's disease. In Addison's disease, the adrenal gland fails. Cortisol and aldosterone are low. ACTH is high. Patients have fatigue, weight loss, hypotension, hyperkalemia, hyponatremia, and hyperpigmentation. So all these features due to high ACTH. So the causes of primary adrenal insufficiency in Addison disease includes autoimmune destruction, which is the most common cause, TB, metastasis, hemorrhage, and infection. The hormone deficiencies includes low cortisol, low aldosterone, high ACTH. So whenever you see a question mentioning hyperpigmentation and hypotension, you need to think about Addison's disease, primary adrenal insufficiency. So the clinical features in this includes fatigue and weight loss, hypotension because of adrenal insufficiency, because of deficiency of the mineralocorticoids. There may be possibility of hyperkalemia because of deficient aldosterone production, hyponatremia, and there may be hyperpigmentation due to high levels of ACTH. Whereas secondary and tertiary adrenal insufficiency, the problem is in the pituitary gland or the hypothalamus. So cortisol and ACTH levels are low, but aldosterone is normal because the renin-angiotensin aldosterone system, the RAAS system controls it. There is no hyperpigmentation and usually no hyperkalemia also. So the causes includes pituitary disease and chronic steroid use with suppression. The hormone pattern is low cortisol and low ACTH. Whereas in this case, in primary adrenal insufficiency, there is low cortisol and low aldosterone with high ACTH. Whereas in secondary, the hormone pattern is low cortisol and low ACTH with a normal aldosterone level because the RAS controls it. So aldosterone is normal in secondary and tertiary adrenal insufficiency, whereas aldosterone is low in case of primary adrenal insufficiency. The clinical features of the secondary and tertiary adrenal insufficiency includes the typical feature that differentiates it from primary adrenal insufficiency is that there is no hyperpigmentation in the secondary and tertiary cases, whereas in primary there is hyperpigmentation due to elevated ACTH and less severe hypotension, comparatively less severe hypotension when compared to primary adrenal insufficiency because there is normal aldosterone levels. So this helps maintain the blood pressure levels. And so there is less severe hypotension and usually there's no hyperkalemia because of normal aldosterone levels. So this is the key differentiating feature between when it comes to between primary and secondary and tertiary. So now let's try to understand about the cosinotropin test. We give synthetic ACTH and we measure cortisol. In primary adrenal failure, cortisol does not rise, whereas in secondary or tertiary, the cortisol rises if the adrenals are still functional. So if there's no response, then it indicates an adrenal problem. But if there's a response, it indicates there is a problem with the pituitary or the hypothalamus. So first thing, give cosinotropin, which is a synthetic ACTH, and then measure cortisol response in primary adrenal insufficiency because there is a problem with the adrenal gland itself. The cortisol does not increase even with synthetic ACTH. Whereas in secondary adrenal insufficiency, when synthetic ACTH is given, the cortisol increases. So this indicates that there is a problem with the pituitary gland in the hypothalamus, but the adrenal gland is normal and the adrenal glands are still functional. So now let's try to understand about the adrenal crisis. This adrenal crisis is an emergency. It is triggered by stress or sudden steroid withdrawal. So patients have shock, hypoglycemia, hyponatremia, and hyperkalemia. We have to treat them immediately with IV hydrocortisone and fluids. So the triggers of adrenal crisis includes infection, trauma, surgery, stress, sudden steroid withdrawal. The features includes severe hypotension or shock, hypoglycemia, hyponatremia, hyperkalemia. So whenever there's a suspected adrenal crisis presenting with these features and there's a history of these triggers, we have to suspect adrenal crisis, treat first and then test later because the patient can rapidly deteriorate into shock and death eventually. So the treatment includes IV hydrocortisone, IV fluids, and we need to correct the electrolyte balance. So in this part now we are going to learn about congenital adrenal hyperplasia. Congenital adrenal hyperplasia is due to enzyme defects in steroid synthesis. Low cortisol level leads to high ACTH and adrenal hyperplasia with shunting into other pathways. So the core problem is reduced cortisol synthesis leading to increased ACTH, and this increased ACTH leads to adrenal hyperplasia. First thing, so first, let's begin it from the scratch. We identify low cortisol levels. When the body identifies low cortisol levels in your body, it then uh, sends a feedback. Normally, what's actually happening is whenever there's cortisol levels in our body, it just activates a negative feedback to the hypothalamus and the pituitary and inhibits the production of ACTH. When when there's reduced cortisol synthesis, reduced cortisol levels, what happens is that this negative feedback loop, this negative feedback loop that is operating from the adrenal gland to the hypothalamus and the pituitary. So this negative feedback is what happens is this is lost. This negative feedback pathway is lost. So what happens? There is exaggerated increase in ACTH levels. And because of this exaggerated increase in ACTH levels, what happens is adrenal hyperplasia because of overstimulation of this adrenal glands with exaggeratedly increased ACTH levels, what happens is there is exaggerated hyperplasia of the adrenal glands. So this is called as adrenal hyperplasia. So there is shunting of precursors into other pathways, low cortisol, high ACTH in enlarged adrenal glands. So we have studied earlier about how these hormones are synthesized. The first step we have discussed is cholesterol to pregenolone. So we have a different pathway, and we have a flow chart for that for which you can refer to any high yield textbook, and you can identify how this pathway operates. Because it's a really complex thing, I don't want to get into it in this video, but I'll let you know the high yield things in the exam, what we shouldn't miss. So just I want you to learn about that pathway. Go to your standard textbook and read about it, see the image and learn about the pathway and understand it yourself, and then pause it here, come back to this video and study these deficiency disorders of three enzymes that I'm now going to tell you about. So these are really, really high yield, and almost so many questions are tested on these three deficiencies. So there's an enzyme called 21 hydroxylase. So 21 hydroxylase, which operates in this adrenal gland hormone synthesis. So there are different kinds of hormones in that pathway. I need to read it yourself. So the first thing is 21 hydroxylase deficiency. So this is the most common cause of congenital adrenal hyperplasia. So in this deficiency pattern, the cortisol and aldosterone levels are low. Cortisol and aldosterone levels are low, whereas androgens are high. Whereas androgens are high, cortisol and aldosterone levels are low, but androgens are high in the case of 21 hydroxylase deficiency. This is the most common congenital adrenal hyperplasia, and this is also the highly tested deficiency on USMLE. So the clinical features includes salt wasting. Patients have salt wasting, hypotension, hyperkalemia, and virilization. So, the lab clues for identifying this deficiency is that we need to uh, understand that there are high 17 hydroxy progesterone levels. So, when you study the pathway, when you read the flow chart yourself, you will understand what I'm speaking about. So in 21 hydroxylase deficiency, the hormone pattern is reduced cortisol and reduced aldosterone levels, and there is increased androgens. The clinical features includes salt wasting, hypotension, hyponatremia, and hyperkalemia, virilization in females, and precocious puberty in males. The lab clues includes high 17 hydroxyprogesterone. So whenever there's salt wasting and virilization, salt wasting features includes hypotension, hyponatremia, hyperkalemia, and features of virilization in females and precocious puberty in males. You need to think about 21 hydroxylase deficiency. And if the question mentions high 17 hydroxy progesterone, so then it definitely indicates this 21 hydroxylase deficiency. The hormone pattern in this deficiency is low cortisol and low aldosterone with elevated androgen levels, high 17 hydroxy progesterone levels. So the next hormone deficiency we're going to study about is 11 beta hydroxylase deficiency. Here, cortisol is low, androgens are high. Cortisol is low and androgens are high, and 11 deoxycorticosterone, which is a weak mineralocorticoid. So it before aldosterone is synthesized, this is a precursor to say. So when you look at when you read the pathway yourself, you will understand about what this 11 deoxycorticosterone is. So the hormone pattern in this 11 beta hydroxylase deficiency is reduced cortisol, reduced aldosterone, and increased androgens. The aldosterone might be decreased, but the precursor aldosterone hormone, the weak mineralocorticoid 11-deoxycortisol level increases. The precursor hormone level increases and the aldosterone level decreases in 11-beta hydroxylase. Whenever you see a question with 11-beta hydroxylase deficiency, you need to understand that there is an increased weak mineralocorticoid in the form of increased 11-deoxycorticosterone. The clinical features includes hypertension, hypokalemia, and virilization. So whenever you see a question mentioning hypertension and virilization, you need to think about 11-beta hydroxylase deficiency. This hypertension is because of increased 11-deoxycorticosterone. This increases the blood pressure. Although the aldosterone level might be reduced, but this increased 11-deoxycorticosterone causes increased hypertension. So this is what we need to remember. So this 21 hydroxylase deficiency, the key feature is hypotension plus virilization, whereas 11 beta hydroxylase deficiency, the key features includes hypertension plus virilization. So the next thing we are going to study about is 17 alpha hydroxylase deficiency. In this case, cortisol and sex hormones are low, but mineralocorticoids are high. So patients have hypertension, hypokalemia, and sexual infantilism, where there are absent or ambiguous secondary sexual characteristics. So whenever a question mentions hypertension plus no sex hormones, you need to think about 17 alpha hydroxylase deficiency. Reduced cortisol, reduced androgens, increased mineralocorticoids. So this hormone pattern between 21 hydroxylase, 11 beta hydroxylase, and 17 alpha hydroxylase, you just need to memorize these three things because these are really high yield and understanding it would be definitely uh, difficult. So I would like to request all of you to go back to your books and see the pathway. So the hormone pattern is reduced cortisol, reduced androgens, and increased mineralocorticoids. Clinical features includes hypertension, hypokalemia, sexual infantilism, ambiguous or absent secondary sexual characteristics. Whenever you see a question mentioning hypertension and no sex hormones, you need to think about 17 alpha hydroxylase deficiency. So now let's try to compare these three main causes of congenital adrenal hyperplasia. Use blood pressure and androgen effects to identify the enzyme. So 21 hydroxylase deficiency gives salt wasting and virilization. 11 beta hydroxylase deficiency gives hypertension and virilization. 17 alpha gives hypertension and no sex hormones. So 21 salt wasting and virilization. 11 beta, hypertension and virilization, and 17 alpha, hypertension and no sex hormones. So we can memorize it using this quick logic and key logic. So now we're going to study about hyperaldosteronism. Excess aldosterone causes sodium retention, potassium loss, and metabolic alkalosis. So we always need to think hypertension, hypokalemia, and alkalosis. Hyperaldosteronism means excess aldosterone. Sodium and water retention leads to hypertension. Potassium loss because of hyperaldosteronism leads to hypokalemia, and hydrogen ion loss leads to metabolic alkalosis. So whenever there's hypertension, hypokalemia, and metabolic alkalosis, you need to think about hyperaldosteronism. There are different causes of hyperaldosteronism. The primary hyperaldosteronism, also called as Conn syndrome. Conn syndrome. So this is usually due to an aldosterone producing adenoma, which is the most common cause. Aldosterone is high and renin is low. In this case, patients have hypertension and hypokalemia. The cause of primary hyperaldosteronism is aldosterone producing adenoma, which is the most common, or bilateral adrenal hyperplasia. The clinical features includes hypertension, hypokalemia, muscle weakness. So the lab pattern includes high aldosterone and low renin levels. Whenever there's high aldosterone and low renin, you need to think about primary hyperaldosteronism. High aldosterone and low renin. Causes includes aldosterone producing adenoma and bilateral adrenal hyperplasia. So in secondary hyperaldosteronism, here high renin is seen and aldosterone is also high. It is usually due to renal artery stenosis, heart failure, cirrhosis, or nephrotic syndrome. The lab pattern is high renin and high aldosterone, whereas in primary hyperaldosteronism, there is the lab pattern is high aldosterone and low renin, whereas in this case, there is high aldosterone and also high renin high renin. So whenever there's high renin plus high aldosterone, it is possibly a case of secondary hyperaldosteronism. It is due to causes includes renal artery stenosis, heart failure, cirrhosis, and nephrotic syndrome. The screening test that is used for the diagnosis is the aldosterone to renin ratio. A high ratio suggests primary hyperaldosteronism, whereas a normal or low ratio suggests secondary causes. So high aldosterone with suppressed renin indicates Conn syndrome or primary hyperaldosteronism. Primary hyperaldosteronism is due to causes like aldosterone producing adenoma or bilateral adrenal hyperplasia. Whereas if there is high ratio, normal or low ratio, it suggests secondary causes, and the secondary causes includes renal artery stenosis, heart failure, cirrhosis, and nephrotic syndrome. So all these leads to high renin and high aldosterone. Now, coming to the treatment of hyperaldosteronism, primary disease is treated with surgery or mineralocorticoid receptor blockers like spironolactone or eplerenone, whereas secondary disease is treated by fixing the underlying cause. So, primary hyperaldosteronism, surgical removal, and mineralocorticoid receptor blockers or antagonists like spironolactone and eplerenone, whereas secondary hyperaldosteronism is treated using by fixing the underlying cause. Spironolactone blocks aldosterone action, not its production. So, adrenal medulla. Now, coming to the adrenal medulla, the medulla makes epinephrine and norepinephrine. So, these are catecholamines and they act as modified sympathetic ganglion because they are derived from the neural crest cells. So, these are stimulated by the sympathetic nervous system. So, these are also called as fight and flight hormones. The sympathetic nervous system mainly regulates emergency responses in our body in response to stress or sudden severe emergency situations. What happens is the sympathetic nervous system activates and this produces hormones like epinephrine and norepinephrine. So these are also called as fight or flight hormones. So now let's try to understand about how the catecholamine synthesis occurs in our body. Catecholamines are made from tyrosine. Catecholamines are made from tyrosine, the enzyme phenylethanolamine N-methyl transferase. Phenylethanolamine N-methyl transferase (PNMT) converts norepinephrine to epinephrine, and this PNMT is stimulated by cortisol. That is secreted by the adrenal cortex. So this shows how this PNMT phenylethanolamine N-methyl transferase PNMT stimulated by cortisol from the adrenal cortex. So this helps us understand, and this shows how the adrenal cortex and the medulla interact together. So the catecholamines are made from tyrosine. The pathway is tyrosine to DOPA to dopamine to norepinephrine to epinephrine. The key enzyme is PNMT, phenylethanolamine N-methyl transferase, which converts norepinephrine to epinephrine. And this PNMT is stimulated by cortisol from the adrenal cortex. Now, coming to pheochromocytoma, this pheochromocytoma is nothing but a catecholamine secreting tumor. The classic triad is headache, sweating, and palpitations. often with episodic hypertension. Pheochromocytoma is a catecholamine secreting tumor of the adrenal medulla. The classic triad seen is headache, sweating, palpitation. Yeah, other features includes episodic hypertension, tremor, anxiety. Episodic symptoms, hypertension. Whenever you see episodic symptoms and hypertension, you need to think about pheochromocytoma. Uh, for diagnosing pheochromocytoma, we can screen with plasma free metanephrines or 24-hour urinary catecholamines or metanephrines, and then image to locate the tumor, imaging by CT or MRI to locate the tumor. The first best screening test includes plasma free metanephrines or 24-hour urinary catecholamines or metanephrines, and imaging by CT or MRI to locate the tumor. The first thing is that we have to do biochemical testing first, and then we have to go for imaging. Now, coming to treatment and genetics of this pheochromocytoma, the treatment is we have to treat with alpha blocker first, and then we have to give beta blocker, and then we have to proceed for surgery. Never give beta blocker first because it can cause hypertensive crisis. So the associations of pheochromocytoma includes multiple endocrine neoplasia type 2, VHL syndrome, neurofibromatosis type 1, NF1. So pheochromocytoma, the key is that always use an alpha blocker first, then go to beta blocker. So alpha blocker, like examples includes phenoxybenzamin. So these need to be used first. So these are the first line drugs. If they do not respond to those alpha blockers, then we need to proceed to beta blockers like metoprolol and esmolol. And then if the third line is surgical removal. Never give beta blocker first because it can cause hypertensive crisis. Genetic associations includes MEN2, VHL, and NF1. Now, coming to adrenal pharmacology. So, drugs are used to block cortisol synthesis, block aldosterone production, replace deficient hormones, or control catecholamine effects. So, always we need to match the drug to hormone excess or deficiency. Uh, so, as a whole, adrenal pharmacology, the drugs are used to block cortisol synthesis at the level of the cortex, block aldosterone action, and replace deficient hormones and control catecholamine effects and control catecholamine synthesis at the level of the adrenal medulla. So the high-yield drugs to know includes ketoconazole, metyrapone, spironolactone, eplerenone, hydrocortisone, fludrocortisone, phenoxybenzone, and propranolol. The drugs that decrease cortisol production includes ketoconazole and metyrapone. So they inhibit steroid synthesis and are used in Cushing syndrome, especially when surgery is not possible. So ketoconazole inhibits steroid synthesis and it is used in Cushing syndrome, whereas metyrapone inhibits 11 beta hydroxylase. This is also used in Cushing syndrome. The clinical use is when surgery is not possible or these drugs can be used as a bridge to surgery. So both the drugs reduce cortisol synthesis, not its action. They reduce the cortisol synthesis. Ketoconazole and metyrapone, they decrease cortisol production. So now coming to the drugs that block aldosterone action. So spironolactone and eplerenone block aldosterone receptors. Spironolactone can cause gynecomastia, whereas eplerenone is more selective. Spironolactone can cause gynecomastia, whereas eplerenone is more selective. So spironolactone is an aldosterone receptor antagonist or an aldosterone receptor blocker. It is used in primary hyperaldosteronism, Conn syndrome, heart failure. The side effect is gynecomastia in males. Eplerenone is a more selective aldosterone blocker and it has fewer endocrine side effects. Hyperaldosteronism, you need to think spironolactone or eplerenone. Now, coming to replacement therapy in adrenal insufficiency, in Addison disease or adrenal insufficiency, we replace glucocorticoids, and in primary disease, we replace mineralocorticoids. In adrenal crisis, we give IV hydrocortisone and fluids. In Addison disease or primary adrenal insufficiency, we replace glucocorticoids by giving hydrocortisone or prednisone, whereas we replace mineralocorticoids using fludrocortisone. In adrenal crisis, we use IV hydrocortisone and IV fluids. So primary adrenal insufficiency needs both cortisol and aldosterone replacement. So to solve questions, we need to link symptoms to hormones. So Cushing is high cortisol. presenting with moon phase, striae, and diabetes. Whereas Addison is low cortisol with possibly low aldosterone levels, with features like hypotension, hyperpigmentation, hyperkalemia. CAH is enzyme block with clues from blood pressure and androgens. Conn syndrome is high aldosterone with low renin, and pheochromocytoma is episodic catecholamine excess, episodic symptoms. We always need to remember that ACTH controls cortisol and RAAS controls aldosterone. Always, we have to treat adrenal crisis first. So, Cushing syndrome presents with features like moon phase, striae, and diabetes because of high cortisol. Addison's disease presents with So the features includes low cortisol, low aldosterone. The feature because of low aldosterone, there is hypotension and hyperkalemia and hyperpigmentation. Low cortisol leads to elevated ACTH in Addison's disease, so this leads to hyperpigmentation. CAH, you need to look at BP and androgens. Conn syndrome, primary adrenal insufficiency. Uh, sorry, primary hyperaldosteronism. So Conn syndrome, primary hyperaldosteronism. There is high aldosterone levels and low renin levels. Because of low renin levels, there is because of high aldosterone levels and low renin levels, there is possibility of hypertension and hypokalemia. Whereas pheochromocytoma, there is episodic symptoms like, and there's also a triad we have already discussed of headache, sweating, palpitations. So we need to give first alpha blocker and then move to beta blockers. Directly giving beta blockers can cause hypertensive crisis. So ACTH controls cortisol, RAS controls aldosterone. Uh, Blood pressure, potassium, and androgens are the diagnostic clues in any question. We need to treat whenever there's a adrenal crisis, we need to treat adrenal crisis first and then investigate later because the patient might proceed to shock very rapidly. So we need to take care of the patient not getting into shock. So in the next video, we will try to understand and study about how the pancreas functions, the pathophysiology of diabetes, and how the hormones like insulin and glucagon regulates blood glucose levels in our body. So we'll study everything about pancreas in the next video. So for the upcoming videos, this series, do subscribe and keep supporting. So this USMLE with a Warren educational series is brought to you with a motto to buy you people some time to just sit down and do some active learning rather than endless videos. I hope it helped you. If you believe and like the series, don't forget to subscribe. And I would like to request you that recommend you that watching these videos at 1.5x will definitely save you a lot of time and help you read your books and solve more questions. Thank you. See you again. Bye.